Okay, so the agenda, get out of the way, do this. So the agenda, I'm going to make opening remarks. Again, this is condensed effort for those just joined on the phone. We're going to talk about the quest, our quest for the bill. And I'm going to turn it over to Representative Dillon, bill sponsor. He's going to make some opening remarks. Mike is going to go through some of the details of the bill and some of the actions, specifically New Mexico and Washington, and what they have done relative to a public plan. We're going to talk about a little bit of the learnings from the co-op. Don't repeat some of the histories of the past. And we're going to facilitate a discussion. So we hope that we're through our prepared remarks in about 30 minutes, and we hope that we're on to stakeholder feedback and for about an hour post that, subject to a little variation. So some opening remarks. First of all, thank you. Thank you for being here. When I think about what is most unusual of the state and one of our gifts, it's our collaborative nature. It's the ability for us to work together from across party lines, across interests, to find compromise and to find that which we can all celebrate and that which meets the needs of the. So I want to thank you. I have had the privilege of being in the healthcare market for now, I think, 34 years. And I've built products in every single state in this country. And I can say with full conviction, there's no state that's more collaborative than Colorado. That's our gift. So we have the ability to make what we'll call beautiful music out of this. Beautiful music out of this. So let's set our intentions on that. How do we do what others may not have been able to do? How do we maximize all of our strengths? And let's one really neat thing about Colorado is we have a lot of pretty strong carriers with some even balance. So you can go to parts of the country where one payer might have more than 90% market share. This state, these are general numbers, they'll be directionally very close. United on the commercial side or private side, around 24% market share. Anthem around 2021. Kaiser around 1920. Cigna 17, 18, 19, somewhere in there. And Aetna about 7. Doesn't need to have that much strength. We have a really strong exchange. The increases this year were in the single digits. Thank you, Kevin. Really wonderful. We have bipartisan interests. We find commonalities. The reimbursements are pretty reasonable. We've got some issues in the Western Slope we're addressing every day and working harder to, but we have strong provider collaboration. Thank you, Colorado Medical Society and Colorado Hospital Association, for being here today. So we have a lot of strengths that we can build off of to make beautiful music. As we learned from our history, Michael talked more about this. I've commercial hat for a lot of years. I've been a consultant for Medicaid. I'm now executive director of the Medicaid program, and I know what it's like to try to get a health plan up on an exchange. When you put a plan out there and you're not really sure who's going to sign up, and you have to take financial accountability. I know what that's like to do in a variety of ways, to be accountable for bringing in membership growth, for Wall Street and nonprofit, and so if you look at that awesome accountability, got to grow, and you have to maintain financial integrity, or you go under. Think about our co-op. Think about what happened here. I can remember making a call early on as running a health plan, and the health plans, when one of them goes under, the others have to pay for that. The others have to pay for that. I can remember when our co-op came on, and the price was put on the market less than Kaiser. And I called Marguerite Salazar, who was then the commissioner, and I said, sister, got to have breakfast. How is it possible? Somebody without a Kaiser infrastructure can price below Kaiser. Red flag. Boom. Red flag. That is not sustainable. And there it went. Boom. You need to learn from that. You can't just lower prices in order to lower prices and have it sustainable. You have to learn from that. Most all the co-ops that started are no longer functioning. They went under. We need to learn from that. So how do we together use our amazing gifts and our strengths to do what others have not been able to do, to learn from some that are a little farther ahead of us, Washington and New Mexico, to hoist the insights and the passion of the advocates to find the right solutions, to maximize our elected officials, and do something pretty awesome. So I'm going to lean on our governor's principles. When the governor interviewed me and when he was talking to his cabinet, he said, there are 4 things I want you to be and I want us to do and I want us to lead. And I think they can guide us through this process. 1, he said, I want you to be bold, fearless. Bold and fearless is unusual. Bold and fearless. But I want consistency. Consistency. I want low, unforced errors. And I want you to be joyous. That's what he said. And every day, we're coming in the cabinet, that's what we're doing. Those are good sites for us to say. Bold and fearless, we should be innovative. Do some things that are different. Innovation is one of the strengths here in Colorado. We have the ability to be the innovation healthcare lab for the country. Between the Catalyst site, the DPC, the amazing gifts in our university, the amazing gifts at CSU, Colorado Springs, rural communities, we have the ability to maximize those gifts. If we use those 4 guideposts, we could really do something special here. Again, bold and fearless. Let's be joyous. Let's look to consistency. Man, low unforced errors. The one thing that I'll end on this slide with what I started with, the beauty that we bring is our collaboration and diversity of mind. I just want to get some hands. Where are the payers and carriers in the room? Okay, got them. Where are the providers in the room? Good. Where are our advocates in the room? Our elected officials and our government representatives, the legislators. There you go. A little fat one over there. Hold on. What did I miss? Did I miss? Okay, that's a nice collaborative forum, so thank you for your diversity of thought. All right, so what does this bill ask us to do? It says make high quality healthcare access available to every Coloradan. That's what it challenges us to do. Today the uninsured rate is 6.5%, but it is not evenly spread. Right, we've got certain areas that are over 15% uninsurance, Pueblos, you know, in double digits. A lot of our rural communities, and we have with some of the rhetoric coming out of Washington, the words public charge have upset our non-citizens. They're upset folks. So that in our rural communities, some of our Latino communities, we've got an increasing uninsured rate. We recognize that. Sustainable affordability to customers at different income levels. We need to serve individuals and small employers. Address the uninsured rate. Maximize existing infrastructure. Like I said, we have so many neat strengths. Don't disrupt what's not broken. Maximize innovation. Recognize the federal challenges in funding. You might remember the federal government said, hey, I'm going to pay you so much money on the dollar, somewhere around 80 plus cents. And then towards the end, they said, you know what, I don't have that money. So sorry, here's less. Oh, right? And that funding is inconsistent. And the co-ops had significant challenges, including ours, when that happened. The carriers were largely able to absorb. Rocky Mountain had some tough times, and there came the merger and acquisition post that. What does it also say? Let's increase competition. That's our quest. Let's collaborate and make some beautiful music together. So with that, I want to turn it over to Representative Dillon. And after that, Mike's going to walk through the balance presentation, and then we're going to open it up for stakeholder comment and input, which is the most important part.
All right. Should I stand here so we pick it up? Okay.
Sure.
Yeah. Thank you. I won't take very long at all because I know you all have a lot of important work to do. I think I know a lot of you in the room, but if I don't, I'm Dylan Roberts. I'm the state representative for House District 26, which is Eagle County and Route County. And I came down from my district today because I wanted to be here for this exciting first meeting House Bill 1004 was something that I've been working on along with Representative Catlin and Senator Donovan for quite some time, along with so many people in this room. So I first want to thank everybody who made House Bill 1004 happen and make this process happen because this is really exciting. And as Kim said, we are one of the leaders in the nation with starting this process and getting this product off the ground. And that's because more people in Colorado deserve access to health insurance, and increasing competition and trying to find an affordable option for folks who don't have access to that right now will mean a whole world of difference for people in my district in rural Colorado, but all across the state. And when we were thinking about House Bill 1004 and talking about the stakeholder process, we envisioned a day like this, but to actually see it happen with so many diverse people here is incredibly exciting. So I just wanted to be here to thank you for all the work you have done to make today possible and all the work you're going to do this summer and this fall to prepare the option for us. I know it's going to be a lot of work, and I know we have a lot of diverse opinions, but I know that when you guys present your report back to us in November, that we will have a very well comprehensive stakeholder process, and that's what we envisioned. We wrote the bill in a fairly broad way, so we can give you all a lot of discretion as you go through this process this summer to come up with the best plan that works for Colorado and works for everybody involved. Not just what one legislator envisions, but something that actually works. So I am so happy to have Kim and Mike on board and help us get this through the process. And I know you're going to lead a great process, and wanted to thank everybody in advance for their work. And I look forward to coming to as many of these as possible, but at least staying up to date and helping in any way that the legislative branch can. So thank you so much for having me today. Appreciate it.
Yeah. So as we're changing over, I just wanted to do a couple ground rules. That's what we always have to do as facilitators. So please make sure your phones are on vibrate. I'm going to ask everybody to use their outside voice. We have one mic, but there's a lot of you in the room. So pretend I'm your new puppy and you're just trying to get my attention, and I will gladly call on you for the place. There is going to be a place for you guys to give feedback. So important to listen and hear some of this, but the feedback is some of the most important part. So we'll be calling on you for that. So look forward to some good dialogue, conversation, restrooms outside. Again, we have probably over 40 people on the mic. We heard the dings for a while, and then we didn't. So again, we'll be going also to questions for folks on the phone. So I'll be turning around to get some of those. There's also a sign-in that's going around. Please make sure you do sign in on that. That's how we make sure that you know about future meetings and opportunities. So, Mike.
Thank you, Loretta. And thank you, Representative Roberts, for the words and for being here. And I want to echo a few things that he said real quick. I want to thank Healthier Colorado, CCHI, CMS, CHA for being at the table and helping the conversation as we went through this process. I think Kim hit the nail on the head that there's a lot of collaboration in the room. Elizabeth Darnalis, who was key in structuring this from the get-go as well. There's a lot of collaboration in the room. There's a lot of opportunities to help this grow. But I think that as the conversation goes, things are going to get sticky at points. There's going to be hard conversations that are going to occur, that have occurred. So I just want to encourage everyone as we start to have these conversations, that things do kind of grow, that we all agree that we're going to work through those issues. And we're going to stay at the table, and we're going to continue to collaborate, because if we stop talking, that's when things are going to break down. But with that, I'm going to go quickly through the kind of the bullet points of the legislation and talk through a couple of other things that Kim and I, as we put this together, thought it was important for us to be considering as we do this work. But really, if there are questions as we go, please don't wait until the end. We can keep the conversation going as I go through these slides. If there's things that you think that we aren't highlighting from the legislation, especially those folks that were very key in the legislation, please stop us and let's have that conversation too. So with that, jumping into it. So what does the bill require us to include in the proposal? So the bill has multiple parts, but there's really kind of three structural components of it in the bill that we really focused on as we were putting this presentation together, that we thought it was important for us to highlight, to use as our guideposts as we're doing all of this work, as we're having all of these conversations. So what we need to include in the proposal is the feasibility and cost of implementing a state program. We have to identify the most effective implementation of a state option based on affordability to consumers at various income levels. So as we know, the income levels, as far as the ACA is concerned, is very key up until the 400% of the federal poverty level. And that's where your subsidies stop for folks. So the conversation, I think, can go in a lot of different ways. We can focus on the income levels over 400% and the folks that are struggling at that level. Folks between 250% and 400%, though, also, they do get subsidies, but they struggle as well. So I think there's a conversation to be had on that front. On the undocumented piece of the population that don't get any subsidies, that can be part of the conversation as well. So the administration and financial burden to the state, the risk-bearing and the solvency aspect of starting up a health plan. We're going to talk a little bit about the co-op as we go, as a couple slides from here. But there's significant startup costs to effectively a new health insurance company. So if we're having that conversation, if that's part of this conversation, we need to be cognizant of what those startup costs are, including what will be required to actually meet the solvency requirements. So at the Division of Insurance, we're going to require this entity to be able to meet the same solvency requirements as any other insurance company would. Those are significant, and those can be very significant for a startup company. The ease of implementation. So that one is fairly self-explanatory, but we got to figure out how difficult it is going to be to stand this thing up. Evaluate the likelihood of meeting the objectives above. So the objectives above are really what Kim touched on here. So these are the main objectives of the legislation. This is what the nuts and bolts are, what we're going to keep coming back to when we're trying to decide what we think we should go forward with. So the other big key, or one of the probably the biggest key for our conversation, is the fact that we have to have a proposal to Representative Roberts and his friends on November 15th of this year. That's effectively 5 months away, folks. And that means that we have to have a draft out for you all to look at and tell us if you think that we missed something, if we have something that we should include. That means that we're really looking at 4 to 4.5 months of time where we can actually do this work. That is an incredibly short period of time. So it's going to take a lot of commitment on everybody in this room to be willing to be thought partners and leaders and help us figure out where we think we should go with this. So keeping on the implementation considerations, we have to identify potential premium levels and cost sharing for a plan that's going to be an EHB compliant plan. EHB is an essential health benefit compliant plan. That's an ACA plan. So everything that you're used to going on to the marketplace and buying would have to actually be able to meet these, this plan would have to be able to meet those requirements as well. We got to figure out the provider rates that are necessary for this plan to be able to pay in order to build a network. Some of the folks in this room are going to be very concerned about that. Some of the folks in this room are going to be concerned for other reasons on that front too. Eligibility criteria for individuals and small businesses. So this is going to be one of the first things that we got to figure out. Are we trying to devise a plan that is just going to be for the individual market? Are we trying to devise a plan for the individual market and the small business market? And then although the legislation doesn't speak to this as well, from my viewpoint, if we're going to be including the large business market, I think it does make some sense to have the conversation if we should be devising something that could work for the large group market as well. The large group market, if we can bring them into the mix, it just creates more leverage for this product to be able to actually go out and negotiate a more effective rate than it would if it was just an individual market or the small business market. Any impact to the state budget. So where this becomes key is if this plan is going to be carrying risk, then we got to figure out what the impact of the state budget is going to be. And we'll talk about what that would look like based upon a kind of a comparison to what the co-op looked like and the struggles that the co-op went through. And I'm not going to even touch on the startup costs that the co-op had. We're just going to talk about the struggles from the co-op. And then determining the impact on the stability of the individual market, the small group market, and Connect for Health Colorado. So Kevin is here. Kevin is going to be an active participant in these conversations so that we're very cognizant of what the impact could be, not only to the individual and small group market, but we need to be thinking about the investment that we made into C4. Some of you have heard me talk about C4, but I think C4 is one of the greatest untapped resources that we have in the state for all the things that it can do on top of all of the great things that it's already doing. So, for example, this is going to get into the health policy weeds a little bit, but last year, when the risk adjustment somewhat crisis started to happen, when the federal government was making noise that they weren't going to make the risk adjustment payments, we were going to have an opportunity to deal with that problem in Colorado in large part because we had our own health exchange. If that wasn't the case, then the federal government had actually gone through with their threats or what were their perceived threats to not make the risk adjustment payment, we were going to be in a very, very bad spot. So it's those kind of things like that untapped resource that I don't want us to forget about as we're having these conversations. It's incredibly important to me that we make sure that as this grows and as we evolve with this conversation, that we make sure that C4 is a viable partner. So, implementation considerations continue. So again, determine the impact on individuals receiving subsidies, The structure of the plan, including who should offer it, any impacts to HIPAA, if there could be any, the funding options, including state funds and federal waivers, the feasibility, legality, and scope of any necessary federal waivers. So the key there is any necessary federal waivers. I think the way that Representative Roberts and the sponsors of the bill structured it, it isn't necessary that we would have to go out and get waivers in the front end of this plan, depending on what it is that we put into the plan and how we stand it up. I think that there are some very valid reasons why we may want to go and get a federal waiver so that we can take some of the savings that we're going to actually provide to the federal government, put them back into the plan. But candidly, with this administration, as we learned with the reinsurance bill, it might be a struggle to get some of the waivers through that we might want to get through. So all of that being said, we need to be smart about what we're doing with the federal waiver component. I think we may want to build it out so that what we're doing has the potential to go and get a federal waiver in the future if we don't think that we can do it now. But it's something to keep in mind that this just calls for us to evaluate any necessary federal waivers, and there may not be any necessary federal waivers on the front end of this. So information related to Senate Bill 19004, which was another bill that Representative Roberts sponsored, which at the end of the day, originally had two pieces of it, but through the evolution of the legislation, it ended up with just the cooperative component of it. When I'm talking about cooperative, it's a different idea than the co-op. This is a purchasing cooperative. It's what's being stood up with Peak Health Alliance up in Summit County. And then we have to create a statewide definition of affordability for consumers. So that piece is consistent with two other bills. So we have to look at, come up with a definition of affordability as part of the reinsurance bill, and then also as part of the primary care bill, we have to do it there too. So we need to be cognizant of the fact that this conversation is going to be happening in a few different spots in the implementation process over the summer into the fall. So we're going to be cognizant of that as we come to you all with what we think should be the definition, knowing that it's going to have something that's a bit bigger impact than just this conversation. So the stakeholders' role in the recommendations. So this is, I think, key for what we're looking for you all on. First and foremost, we need you to advise us on the recommendations to the legislature. So we're going to be coming to you, and we're going to start with the stuff that other states have done, primarily, as Kim said, New Mexico and Washington. But we'll be coming to you all with ideas. We want you to come to us with your thoughts on those ideas, and if you think that we're missing something, if you think there's a better idea that we haven't thought of, we want to hear about that too. Constraints. So keep in mind that if there is going to be a need for whatever we're doing, wherever this conversation is going, whether it's a recommendation that we're bringing to you all or it's something that you think that we should be moving forward with, if it's going to take legislative changes, it's going to take another bill. If there's going to be funding requirements from the state, that will take another bill. So keep that in mind as we work through this, that this legislation was really drafted with the idea that it wouldn't take any future legislation. So if that's the direction that we go, then we need to be cognizant of the fact that there are going to be limitations on what we can do. Stakeholders' responsibilities. Be thought partners. We need additional needed input. We want you to share with your community and bring back the ideas that you all have after you share it with your community. And including in that, and I know you all will not be shy about this piece, but if you think we're doing something wrong, we need to hear it. I don't want to get to October and start receiving letters from everybody telling us that what we've been talking about for the last 4 months is a really terrible idea and you're going to be fighting us tooth and nail at the legislature. Let's have the conversations as we go, folks. That's why we're going to be having these meetings. That's why we want you all to be here and present and actively engaged as much as possible. And then the last piece, the stakeholder feedback will be used to inform recommendations, which I think is hopefully somewhat obvious at this point. So the criteria, this is really just kind of a repeat of what we went through before. So we're going to be focused on the stability of the market, competition without harm. So inherent in the idea that we want to increase competition is the fact that we need to keep the competition that we have in the marketplace. We need to add competition into that, but subtracting won't get us anywhere. Affordability to consumers at different income levels, ease of implementation, likelihood of success, and then the high quality. So there'll be others that you all are going to want us to focus on, and as when Lorez gets up and we start having a kind of more active conversation, please chime in. So the New Mexico analysis. New Mexico has been looking at this for a number of years. I think they're going on to their third year of review and analysis into what could be a public option or a Medicaid buy-in, depending on how you want to phrase it. So the first piece, to offer Medicaid-like coverage off the marketplace to those not eligible for Medicaid, Medicare, or subsidized. So this is everybody in the individual market above 400% of the federal poverty level. So it's the folks that really are the ones that we hear about quite a bit that are struggling in the marketplace, the people that, especially in our mountain areas, where Representative Roberts is from, we hear conversations that are very true and very scary that they're paying the same thing for their health insurance they're paying for their mortgage, if not more. So that's what that one would focus on. The second one, state offers the low-cost product on the marketplace to the individuals in the marketplace and small employers. It would be a QHP, so it would have the essential health benefits, and it would be a partnership with an existing insurer. So this one, the insurance company would carry the risk. The state wouldn't be carrying the risk. And I don't think that they envision on the first one that the state would carry the risk either. I think that's more of an idea that there would be some companion with an insurance company. The basic healthcare program. So this is going to be focused more on the undocumented population. This is anybody and everybody would be able to buy into Medicaid if you are below 200% of the federal poverty level and you aren't otherwise eligible for Medicaid. So that really, I think, for all intents and purposes, is focused on the undocumented population and making sure that they have a product that they can afford. The Medicaid buy-in for all. That one is pretty self-explanatory. That is the state carrying all of the risk. It opens up Medicaid to anybody and everybody that doesn't, except for the Medicare population. Everybody would be able to go in and buy into the state's Medicaid program. The state carrying the risk on that, though, does carry substantial risk. And that needs to be something that we're talking about and that we're figuring out as we have these conversations. Washington State. So Cascade Care. This is something that I think is interesting and may have some promise across the board, in particular in Colorado. So this was signed into law in 2019. The coverage starts in 2021. It's a hybrid. They call it a hybrid public-private system. So effectively what this is the state is going to go out and they're going to negotiate contracts, or they're going to go out with a set contract and encourage providers to join their network. But the contract's going to be at 160% of Medicare. And I'm sure that's going to raise some eyebrows in the room, and that's going to cause some consternation. But that's how they're going to make this plan affordable. That the plan is going to pay at 160% of Medicare. It's just for the individual market. But the key from my viewpoint is that the state doesn't carry the risk on this. The insurance companies still carry the risk. So we don't have the inherent problems and the inherent questions that would come along with the state carrying the risk. What was the percentage of Medicare? 160. And I believe that's a blend of inpatient and outpatient.
So if we can also just make sure we repeat the questions, because I'm not sure that everybody can always hear that.
Yeah. So the question was, what was the percentage of Medicare? And the percentage of Medicare that Cascade Care would pay to Washington Flat is 160% of Medicare. So the co-op. As Kim touched on earlier, there were 23 co-ops that got stood up as part of the ACA. We are now down to 4. We had a co-op in Colorado that failed. And I would slightly disagree with Kim, or make one slight correction. It isn't the insurance companies that pay for that failure. The $110 million that was assessed by the Guarantee Association, that was paid by everybody, the consumers in the state of Colorado. The insurance companies have to put that money up front. That is absolutely true. The consumers at the end of the day are the ones that are on the hook for that. So that's $110 million that the state had to pay, the state consumers had to pay, in order to make sure that for really the last 6 months to 9 months of the existence of the co-op, that those consumers' claims got paid. So I think it's important for us to at least talk about and think about the co-op experience, as Kim said, so that we make sure that we're not going down and making the same mistakes of the co-op. The co-op was dependent upon federal money for its startup. It got all of its startup funds it was required by statute and regulation to get all of its startup funds from the federal government. Then on top of that, the co-op became very dependent upon the 3 Rs and getting the 3 Rs paid to them. There were other problems, and I'm oversimplifying this to some degree, but those were the 2 things that ended up taking down the co-op. When the risk corridor money went away, the co-op around the country, a large number of the co-ops around the country that were still up and running, failed as a result. So I think it's really important for us to realize that the reason that the risk corridor money went away was because of political gamesmanship at the federal level. anytime that we're putting something together, a health plan a health, anything related to a health plan that is going to be dependent on federal or state money, we have to be cognizant of the fact that there will be political games that are played with it, and we need to at least be able to try and build protections around it if that's the direction that we're going to go. If not, then we're going down the path of setting ourselves up for a very similar failure to the co-op. The co-op, the reason the risk quota on money went away was because Marco Rubio pulled a fast one and got the Obama administration to agree to a budget that did away with the risk quota on money. I mean, that was the gist of it. And then the co-ops started to fail throughout the country as a result. So the failure of the co-ops, the other piece that I really want to make sure that we're all cognizant of and we're thinking about, it impacted thousands of Coloradans, tens of thousands of Coloradans, hundreds of thousands of people throughout the country, and it cost billions of dollars. In Colorado, like I said before, it was a $110 million hit to Colorado consumers when that went down. But to put a finer point about it on why it went down, in 2014, the underwriting losses for the co-op were at $8 million. In 2015, the underwriting losses were at $63 million. That's the kind of risk that we're talking about putting together. So we need to be cognizant of that as we're looking through, when we go back to those guideposts, we're thinking about the fact that we need to discuss and come up with a plan for the state budget and how this is going to impact or potentially impact the state budget. That's a piece of the puzzle that we have to be cognizant of and we have to be talking about. So we're going to turn it over to Lorez at this point. She's going to facilitate the discussion. We're going to have information up on this website as we go throughout this process. We'll have a landing page on the division website too. But really, please, we're here because we want to hear your thoughts. We want to have an active, ongoing discussion. So please jump in here with all you got. Lorez, I'll turn it over to you.
Again, thanks everybody. So we are going to now move, it's your time to ask questions, and I'm a pretty loud speaker generally, but I will put this on. So the first thing I wanted to find out, were there any questions on what was said before? Maybe not let's get deep into the models, but you just got a lot of information from both Kim and Mike, and so if you can, or Commissioner and the Director, so if there are any questions about those pieces, just wanted to give an opportunity if anybody needs clarity on that. And if people can just introduce themselves when they ask questions, and then I'll repeat the questions for folks on the phone to make sure they know what we're answering. Yes, please.
My name is Colleen Stout, and I worked in healthcare for the last 40 years. Both on the
It'll wake up.
Oh, only one mic can be on at the time.
It'll wake up. Yeah, you take yours off.
maybe.
Yeah, just talk.
Yeah,
There you go.
there we go.
So I've been in healthcare for about 40 years, working on the hospital side, the doctor side, the patient side, consultant side, just consumerism in general. And now I'm paying my own health insurance. So now I'm on the painful side. And I'm just kind of curious what's off the table to not touch. So we talked about all the things we should really include and address, but are there some things that are like the forbidden topics? Is pharma a forbidden topic? Is outsourcing the buying groups outside of the United States a forbidden topic? I mean, knowing what not to touch is almost as important as what we need to accomplish.
Appreciate that question. I'm going to give.
So this is Kim Bimsteffer. I'll take the first stab at that. This is Kim Bimsteffer. I'll take the first stab at that and then turn it over to Mike to add some color. But this is a stakeholder meeting, and the beauty of Colorado is our innovation and our collaboration. So for now, outside of what might be way out of bounds, I got other countries, let's settle back on that one. Other than that, let's open it up to your creativity within the guardrails of what we just warned. Learn from the history. We have to be fiscally prudent. We have a lot of payer experience in the room. We have amazing providers. Let's find what Mike walked through with you is just where some folks are that are ahead of us. Those are not guardrails for us. We do not need to stay in those zones. We need to learn from them and watch them. So with that, Michael, add some color.
Yeah, I think that's right. As far as if we're talking about other countries, you're going to make a lot of people very nervous, including me. But I think the whole idea here is that we want everything and anything to be put on the table within reason so that we can flesh it out and have the conversations of whether it makes sense. I think Kim's right that there are other states that are ahead of us and they've done a lot more work than what we just presented here that we can learn from and see if there's something there that makes sense for us. But if there's something that isn't on that list that other states haven't looked at that we do think is a good way to go, that's why we're going to have these stakeholder meetings.
Other questions? Steve, if you can use your outside voice, I won't run with the mic.
I absolutely will use my outside voice. First of all, thank you very much, Representative Roberts. And my first question is, other than you and me, is anybody here from Western Colorado?
So there was a question.
I think on the phone.
Yeah. So,
That's great. My question is,
yes.
we talked about lots of possibilities we could go here, we could there. We didn't talk about geography. Are we looking for something that will apply across the board, work in Denver, inner city Denver, work in Durango, work in Gray, work on the Eastern Plains, or do we have the luxury or the option to look at the areas of the state that are having significant issues right now, Western Colorado, and look at building something for only part of the state?
So just to repeat the question for folks on the phone, and I'm going to simplify it, Stephen. Again, if folks can, I love the very sort of diverse questions, but because we have to repeat them, if it can be condensed. But it was a question of, will this be a statewide solution, or will there be an opportunity for some regional solutions or regional pieces, if that's a fair interpretation?
So well, actually she does know Steve very well, but she should know that he doesn't do condensed very well. But I had a feeling that that's where Steve was going with the question. So that's for the folks on the phone why you heard me say yes in the middle of the question. Yes, we're going to be developing something that has an impact statewide and that works statewide. And I think that's exactly inherent in the bill itself. It's required in the bill. The bill speaks specifically to the 14 counties that only have one carrier in it at this moment. And it speaks to the fact that we should be coming up with a solution to increase competition in those 14 counties. So I think we would be dropping the ball if we didn't do that. The other piece that folks in the room have raised to me that I think is of concern that we'll just put to bed at this point right now is we will be going out into other parts of the state to have these stakeholder meetings and to have those conversations. We don't have a plan as I sit here right now because session ended like 5 minutes ago. But we will be getting out of Denver to have these conversations too. It's important for us to do that so that we make sure that we're hearing the voices from around the state and that we're not having just the conversation in Denver with just the folks that always tell us the same things. So Kim, anything else?
I think we had a question right there as well. Yeah.
I'm Kat Meyer. I'm from Benefit Mall, the general agency. I was on the shop manager at Colorado for many years. So I'm interested in small business aspect of this, what your thoughts are on what you're trying to accomplish there, and also large business. What kind of need are you trying to solve there? Well, so I'm wondering what your vision is.
So just to repeat the question, it is sort of, again, apologies if I shorten it too much, but what is sort of the perceived or hoped impact on both the small and large group markets where there might or might not be a need to do something?
So the small business piece is specifically in the legislation. So I would turn to you all and ask the question, do you think that we should be focused on just the individual market? Do you think we should focus on trying to find a solution for the small group market as well? And I would push back a little bit on, I think if you talk to employers in either the small group market or the large group market, they would probably tell you that they don't think it's working. They would tell you that things are too expensive. They would tell you that right, but so the statement back was healthcare is too expensive. Absolutely the case. Right, and that's exactly what we're trying to solve for. So as part of that conversation, if we're trying to come up with an affordability, right, as the legislation tells us to do, if we're coming up with an affordability definition for the state, does it make sense for us to have that conversation more broadly? That was the only piece that I was putting into the conversation, asking you all to think about and come back to us with any thoughts. Where it goes from there, I think can go in a lot of different and interesting places, and I wouldn't want to presume that I have all the right answers. But I would want to hear from you all if you think that does make some sense.
Let's turn that one off. I think this is Kim. What I'll add to that. This is Kim. What I'll add to that is it's just harder for large employers that are decentralized. So if you are American Express and you have some employees here, that's harder for them. If you are Sisters of Charity and you have most of your employees here, it might be something you want to look at. The issue of that health insurance increases have been more contained, but the starting point is too high and everybody shares in that problem. Just harder to solve for the multi-site large employers who aren't often interested in this sort of local solution.
And for folks on the phone, we are taking questions from you all and monitoring that. So if you want to enter any questions you might have in the chat function, we will weave those into sort of other questions and comments. Yes.
Jessica Morgan, I'm the Legislative Director for the Colorado Association of Health Plans. Just a quick question, and you may not be here yet. But do you anticipate that the public option will have to follow the same rules, not just solvency, but the same rules as the current carriers, network adequacy, that type of thing?
And so again, just to repeat the question, it was, as this new public option comes online, will it have to follow some of the same rules as other market players currently?
So yes, from my viewpoint, it would have to at this point. I think if there was a push for it to have separate rules in some meaningful way, we would need legislation to really kind of address that and spell out what those separate rules would be. Otherwise, I think it's just almost implied in the legislation that they have to follow the same rules. I mean, that's why the legislation speaks to the essential health benefits, and solvency would fall into that bucket too.
Other questions? Yes, please. And I'm just going to own there's a big poll, so anybody sitting behind the poll, you're going to have to really make yourself known if you have a question. But yes, please.
I'm representing Colorado State Association of Health Underwriters. The question is, if the public option went out to the small employer group, what would happen to those groups that actually resided in Colorado but have employees in other states?
So the question is, what happens if the public option or the state option is expanded and is offered to the small group market? What happens to those small employers that have employees in both Colorado, but more specifically employees? Let's put that into the kitty for the piece of the conversation for us, the things to figure out. But I think it would act just like the market does now. And I can't think of a reason why it wouldn't. But if there's something that's giving you pause, Jackie, about that, then let's talk that through.
Yes, please.
Allison Somerton, Aurora Coverage Network. My question is there a data resource that we're using to focus and hone in on where the needs are? Are we looking at premiums? Are we looking at populations? I've heard geography. What is it that's helping to bring and use as a focus on this? So the question was, what's the framework that we're using as focus of what are we solving for?
And the data.
And the data.
That need.
So we have some historic data that defines the uninsured. We have lots in the all-payer claim database, and the commissioner has a lot of history on rate increases. But those are subject to change. As I said, some of the stimuli are changing, which is causing a change in uninsured. So we have two work streams going on to start, which have already been moving. One is the CHAS surveys. I think CHI is in the room. CHI, there you go. And they're defining for us, which will be done about September 1, some details on the uninsured rate. And that by county, community, far more detailed. And we met with them to ask them to expand that a little bit, knowing this work was coming. The second consultant already in place that we should have some work off the calendar on June 30th is analyzing Medicaid churn. So when you look at what drives some of the complications that we're trying to solve for, when somebody comes off of Medicaid and they're trying to rise, there's a little bit of a cliff effect. They go off and onto the exchange. But we have in this state and or in this country, we used to be 1 in every 3 people that got their that worked for an employer of less than 50 lives. 1 of every 3 was uninsured. The ACA came through and lowered that to 1 in 5. Wonderful. That's still, it's 19.5%, most recent figures, which is a lot higher than 6.5% in the average. So we need to recognize and study what's going on with those small employers, because this is a small employer state. We have to figure that out. So one of the studies is churn. One of the studies is where's the uninsured coming from. So if you look at the churn, so Medicaid onto the exchange or onto a small employer plan, which might not provide insurance, Medicaid churns with corrections, back over, and studying the non-citizens. So that the churn in combination with the CHAS study should give us really nice insights in complement to the insurance department's rate increase and in complement to whatever we can get out of the all-payer claim database. And we've learned more recently and are challenging ourselves to rise. The corrections doesn't put their data into the all-payer claim database. So you might see a budget request in this coming budget to try to help that be fulfilled, that gap be closed.
And so that will almost be a nice transition, because I think we'll start to move into questions after Catherine's questions to think about what else, what other models do you want to hear about, and what is sort of the data? You know, we've heard about sort of what is some of that data that we already have or are looking to get. Is there additional data that would be interesting to you all? If we can, we got a question about will there be broker compensation in this public option? So I think we're starting to get into the details of a model we haven't quite yet built. So I'm going to maybe at least acknowledge that question happened, and then we'll put that in with the sort of how will this work with the rest of the market. But again, let's not get into the details of a model yet, because we haven't defined one yet. But really, let's start thinking about what do we need to help create that model. Catherine.
Teed up my question well, because it's building off of Allison's a little bit. And thanks for already kind of providing the landscape of the uninsured data that we're looking at. I think that's certainly a key question. But I think what I was thinking about during that overview of the CHAS and the other data that's being looked at is, are we really trying to solve for the uninsured or affordability more broadly? Because one of the downstream effects of ACA and the coverage expansions we've done is that we've also seen a commensurate increase, a probably disproportionate increase in the underinsured, right, which has a direct tie to affordability, has impacts with Colorado families and on providers. And so I would maybe say tee up the data needed question a little bit, is we probably need to also be looking at not just uninsured and churn rates, et cetera, but also what that affordability looks like and some of those downstream impacts on the overall healthcare ecosystem from a financing perspective.
So I will paraphrase. I don't think there was a question. That was more of a statement. But
She was.
So it was a statement about the data that we need, I think, more than anything else, and the data to look at what the affordability requirement, what the affordability definition really is. To paraphrase, I think what you were saying, and including in that the cost shares and the increase in the cost shares that have occurred really from 2014 up until today. And and there was maybe an inherent question in there, but correct me if I'm wrong, Catherine, that the question was, are we focusing more on affordability or the uninsured piece? And I think you're right in the piece that you said, that those two do work together. I think if we can actually get to something that is truly affordable, wherever we land on that definition, including the cost share component to it, that we will deal with the uninsured problem as a component of that. I do think that those two things walk hand in hand, but I think it's important to realize that the reason that why in large part why we've seen both an increase in premiums and an increase in cost shares is because costs have gone up continuously over a long period of time. And that's how the insurance companies have dealt with it. In order to actually try and keep the premium piece as affordable as they can, they've bumped up the cost shares. So that's got to be part of the conversation. I think you're absolutely right that we need to focus on that too.
Yep. I'm just going to make sure. So I am going to really try to also make sure we hear from everybody in the room. So I am going to move us on to data now, needed data. And it is your question. Yeah, feel free to ask the question.
So in the data needed, and to your point, and your
name?
everybody, Helene, so, in the data needed, where one of the biggest places that I think we fall short of data every time we talk about this is where are the costs, where very specifically are the costs going up? And it needs to be broken down into lots of different buckets, because you can't really hedge your bet if you don't know where you're starting.
Other thoughts on data and data needs that... Yep, sorry.
This is Kim Bimsteffer. So to answer the question on where are costs going up, what are the drivers, and what are the solutions, there are a couple things going on. We did release a cost shift report and identified some things on hospital. We'll release a second hospital report likely before the end of the summer. There's a concurrent pathway that's studying pharma, a very deep pharmacy analytics report of where are the costs coming from in big pharma, and what is the relationship between big pharma, PBMs, insurance companies, the $160 billion that is offsets, rebates, compensation, where that gets stuck in the middlemen, the 315 drugs over the last, since 2009 that had 351 extraordinary price increases, which is the doubling. The 1.25% of scripts that drive coming on 50% of spend in pharma by 2020, so now at about 40. So there'll be a very large informative document that says here are some of the drivers and here are some of the solution options, with several consultants working on that, plus our own pharmacy division, as we have $1 billion in pharma spend here. So there's a lot of concurrent work to say what are the drivers, and the reason why we focus a lot on pharma and on hospitals, because that's about 60 to 65% of an employer and a consumer's cost overall. Now that's one part. We've spent some good time with the Colorado Medical Society, who's also framing and helping, and the analytics, which we've asked for the APCD to refocus themselves from a whole bunch of needs that they might be looking to meet the needs of the affordability, analytics, and studies, and the needs of employers who are asking to put their data into the APCD. We had a budget request this past year. We're now funding the bulk of the APCD's budget overall. We're asking them to focus affordability, 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 all of the study work that we just said, and meet the needs of employers. So if they're negotiating with hospitals, or if they need to understand community by community to solve what are the drivers, that APCD that serves the needs of Coloradans, all of us, is really focused on driving to meet those needs in analytics. So our department will take a leadership role. Mike, and I'm sorry, the commissioner and the Department of Insurance, Mike, inside the health cabinet, we have a wonderful lieutenant governor who's taken and is leading the cabinet to lower healthcare costs and save people money on healthcare. She's looking what we call mile wide. And Mike and I and Elizabeth Arnallis as the senior advisor to the governor in healthcare, Casey, who's in the room as well, we got to be a mile deep. So there are a whole bunch of folks that are driving for what are some of the drivers, what are some solutions, and if we can make beautiful music, it's trying to recognize and address those things. And if we recognize those things and Medicaid's recognize those things in tandem, how do we leverage the power of all of that together to work in collaboration with payers, collaboration with providers to address those needs and drive costs down through the formation of a public plan?
Great. So we've heard that the cost drivers and some of the work that HCFA's doing, some more data around affordability, as well as some of the CHAS, the all-payer claims database. Other data or data you think would be important in this conversation?
Hi, Christina Paslewski with Young Invincibles. On the CHAS data and any data on the types of plans that people are enrolling in, so the cost sharing piece, if we could get more detailed breakdowns by age. I think CHAS in the past has been 19 to 64, but knowing that having more young adults in the market can help make the market healthier, getting more detailed age breakdowns for the adult population would be a recommendation I have.
John, your dad?
Yeah.
Carol Pace. I'm a consumer advocate for AARP, League of Women Voters. I'd be interested in the direct comparison of Colorado stats versus New Mexico. Why not just take New Mexico? We have 4 months. and a comparison of Washington State. So a very simple state-by-state comparison with those who are way down the road on some of these plans. Yeah, Kim, who's going to want to say probably the exact same thing that I'm about to say, but keep in mind that the Medicaid population in New Mexico is much larger than our population. And that has all sorts of different impacts that they're going to be looking at and they're going to be thinking about differently than what we would. But I think it's a good point, Carol. And I think Washington might be a little bit closer to what our population looks like, but I think your point is sound that there may be reasons to look at the population basis and see if there's any comparisons. But I think it's also important to remember that there's key distinctions that New Mexico is going to be thinking about things very differently than what we would. But
I'll add a few other things. Again, I've had the privilege of operating in all 50 states, so let's just talk a little bit about New Mexico and the difference. Albuquerque has a split system. You're either with this health plan or that health plan. One is run by a provider, Presby. One is run by a carrier, Blues. It mimics more Salt Lake City, which has the same diversion. We don't have that. We have more of an open market. While we have some higher performing networks and some hospital-based, that's the minority. In New Mexico, it's the majority. Second, Colorado is the #1 economy in the country, and New Mexico struggles to get out of last place. The challenges they have in an economy are nothing to do with ours. Their uninsured rate is far higher. When people get really sick in New Mexico, they start going north and they come to Colorado. So we want to learn from where their strengths are ahead in their studies and why, what they've studied, but I don't think we want to mimic. We want to focus on what's the beauty of the strengths of our market and learn a little bit from them, but not mimic for the sake of time. I'd rather back something up. One of my leadership rules is we do not just get things done. We get things done correctly. So let's maximize all of our strengths, listen to all of you, not jump in a short, and you know, all of us work together to say, wow, we originally had an August 31st deadline. Can you imagine that? Due by August 31st, we got moved back to November 15th. So we want to really learn, build the right things, and learn from Washington. I agree with Mike's probably a little closer to ours, but it doesn't mean we have to lean on all of that either.
And so we did have a question on the phone that I'll just throw out here. It's really talking about sort of the cost of care and that data, in that how do you sort of address the cost of care and balance that with affordability, because some of the cost of care is what's driving up premiums.
So I think that those two things go exactly hand in hand, right? I mean, I think that's exactly where the affordability conversation is going to go. I mean, it's vital to talk about all of the things that Kim touched on earlier, whether it's the hospital prices, the pharma spend that is constantly increasing. How through this process are we going to tackle those pieces of the puzzle? Because if we don't, so I am just a very quick soapbox, huge proponent of the ACA. I think it was incredibly important in vital ways, but it was incredibly important for access to care. What it tried to do on the affordability side of the puzzle, how it tried to get to affordability for folks that don't get subsidies, it didn't quite work. It thought that if we had a big enough individual market, that consumers would be able to demand better prices. For all intents and purposes, and then it put the MLR on top of that, and it thought that was going to be the two components that were going to keep things affordable. That didn't work because it didn't do anything about the fundamental problem, which is the prices that we are paying. So that's my response, Kim.
Any other cost or data requests? Yeah, George.
I'm George.
Can you use more of your outside voice?
Quick question about kind of more macro data. Legislation provides funding for actuarial analysis of the market, whatever solution.
Thanks, George. So it does. We've got, so the question, because George doesn't really have a big outside voice. The question was, did the legislation give Kim and I some funds to actually go out and do some actuarial work? And it did. It gave us funds to do some actuarial and consulting work up through June 30th during this fiscal year. And we're putting together at the division kind of our contracts and our plans to spend that money. It's not a huge chunk of money because we didn't have very much time. We're not going to be able to do a lot of actuarial work with that money because actuaries are expensive. But then in going into the next fiscal year, it also gave us another chunk of money that's what we're going to use it for, at least in part.
Any other sort of data questions, data needs? Yes, Catherine, yes.
Catherine Miller, Colorado Hospital Association. So I think just in the course of the Q&A, there have been a number of things of work that is already underway, which is really helpful. Is there more work that's underway that we should know about?
So from my end, we'll be able to, so the question was, thank you, Loretta. The question was from Catherine at CHA, what work is underway and can we tell you about it? So I'll be able to tell you at the June 13th exactly what we have underway. As you all, for anybody that's been around government, sometimes it takes us a few days or weeks to get through the procurement process. So I want to make sure that we're actually through that before I tell you what we're going to be doing with our money, because I don't want to tell you that we're doing something that we don't end up doing.
Yes.
Helene at HBS, will we have opportunity to get data on the administrative? So we talked about the cost of care, that's really obvious, but it's out of control. But the administrative side of things, the rework and doing things over time, and on both the provider side as well as the payer side. So can we get data as to the administrative costs of healthcare?
On the payer side, so the question was, sorry, Loretta.
I can always take the questions and then you can answer them either.
The question was, hey, how are we going to calculate, how are we going to get data about the administrative costs of healthcare, both from the provider and the payer side? On the insurance company side, we can give you the medical loss ratio numbers by carrier. We can do it kind of more universally for both the individual and the small group market from 2014 on. We've got that data. That's relatively easy to get to. I mean, in that is both their profit and their administrative costs. Kim, I know, has ideas on.
Just this is Kim, the overall numbers on AHIP says that 13.5% is the administrative cost for carriers on average across the country, and Medicaid is about 4%. So there's a difference, but when I first got here, answered our phone in 45 minutes on average for a member. We've gotten it down to 29 minutes as a break point. We're now less than 15 minutes, and if we roll out a plan that answered members' calls in 45 minutes, we'd probably be a little upset. The providers, when I got here, we had pretty difficult challenges because we had switched our payment system, and we were losing providers. We put in a whole lot of fixes. Thank you for the collaboration with both Colorado Hospital Association and Medical Society, and that's now average of the last 5 months, 18 seconds. So we are a long way towards where we need to be, but there are gaps between how Medicaid operates and how the commercial side operates. And some of those lower administrative costs represent gaps in services. So sometimes we look at administrative costs and we say, wow, that's too high. Well, the trade-off is that you give up services that actually lower costs. So when I'm standing before our elected officials and I got to raise the bar here, give me $1, I'll give you $3. So we have to find a balance of the right administrative costs, not necessarily always the lowest administrative costs, to do the right things based on the population that you serve. So inside Medicaid, we represent 42% of the births in the state. So we need programs that help moms get healthy to term. So as we analyze the findings, so we might create in these work teams and input some solutions that make some sense, but as we get the data coming back of what we're really solving for, because we have insights into the problems, those cost control solutions, programs are going to move. And then we have to find the balance of the most efficient delivery of the right services to drive the right affordability, the right trend control with an appropriate administrative cost.
Just one more quick thing to couple with that. I don't know that we have any great data, at least on Colorado specific data on provider administrative costs stripped out from there. CHA has some data on it. But I do think that it would be incredible. I mean, any health policy, it doesn't matter if it's a book, if it's a paper, anything that you trip across that's in the health policy world, It will talk about if we can do something about the provider administrative costs and all of the burden that goes into that because of all the payers that they have to deal with and all the downstream things. I think that's an excellent place for us to be having the conversation and see if there's ways for us to make the system more efficient through something that we model out here in order to help deal with that problem too.
If you look at some of the opportunities that we all can look to, we have in some areas way too much access. Those are largely very profitable areas. Cancer treatments, orthopedic treatments, cardiac treatments, with a wealth and an abundance. Then we have this minimalist access in areas that are far less profitable. Mental health being the leading there. Substance abuse within mental health being leading there. So if we can create alternate payment methodologies in the public plan and mimic them in the Medicaid population, now you might have, say, 30% of the state's population moving towards trying to get rid of those inefficiencies in the system where we have an abundance of providers, which an abundance of providers on healthcare doesn't drive costs down, it often drives costs up. So how do we study the inefficiencies? One of the things the bill challenges to is finding the efficiency in the delivery system. So how do we create, that's when I was trying to say beautiful music. How do you get the right things or actually reward the providers for doing the right thing? Right now the providers are acting exactly as we ask them to based on how we pay them. So how do we be incredibly thoughtful and get on a pathway to a blueprint to get to a very efficient system and lead the country in the efficiency of our delivery? And I would love to see the profits of our providers go up while the prices come down. We get a very stable environment. We have providers coming into the market where we have shortfalls. We have providers exiting where they're charging way too much money as a percent of Medicare. And we have a more balanced delivery system with an efficiency on the administrative side. That's the beautiful music. We're not going to get there by November 15th. It's going to be iterative as we're all working together to improve the system overall with a public plan as part of that solution.
So I'm going to switch us again. Again, I think we've heard a lot about sort of the cost of care, both as efficiencies and inefficiencies as part of those data points. We had a couple more comments on the phone about that, about the reimbursement rates and really the importance of addressing the cost of care. But as we think about the next meetings and how do we get to November 15th and recommendations, who all would you like to hear from or about what? So we heard about New Mexico, we heard about Washington. Are there other models that you all know about that you want to make sure we know about to inform thinking of the recommendations? Or other people in the state that you think it would be important? Yes, sir.
My name is John Levitt. I represent a network of 10 rural hospitals. I have for about 23 years. I link indirectly to another 5. That's a big chunk of rural, and rural is going to go through a relatively more significant, more dramatic, or at least in some sort of different way, a real dramatic shift in transformation in terms of how they deliver care. We're not all going to make it. None of the people that I represent are in Summit, Eagle, Pitkin, the notorious places that are so high. But many of them don't have any bottom line at all now. They were just hit with critical access hospitals with a $20,000 price tag for the reinsurance bill, well-intentioned, but that's larger than several of them's bottom line, period. So I'd like to hear, and we don't have any real examples to look at because neither Washington or New Mexico has finalized anything, but what goes on in the transformation of rural care to those communities and what do those providers look like?
Great. So the question was from John, who's an awesome leader and stakeholder for our rural hospitals and represents a host of them. So summarize impact to rural hospitals and what are we doing to make sure we're thoughtful on that. So one, John, thank you for your leadership. We are right now, for those of you who don't know in the room, and this is Kim speaking, we're working with the rural hospitals, largely with John's leadership, to adjust how we pay our outpatient EAPG methodology and Medicaid because the rural hospitals are so dependent on Medicaid as a payer. And when we move slightly, some of you have heard me say this, but we're walking down the street, we have a piece of lumber in our hand. It goes out 10 feet on either side. It's a 2x8. And when we turn without being thoughtful, boy, do we do a lot of unintended consequence and damage as we turn and harm. And our rural hospitals are the ones that we have got to continue to be incredibly thoughtful. So we're adjusting some of those outpayment methodologies to recognize that the rurals don't have the same consistency of experience and cost and revenue as our larger systems on the Front Range. So we're working with John and his other CEO brothers and sisters in that regard. The second thing is we're working diligently with the Hospital Association on something called the Hospital Transformation Program. And in there's a first provision, and in the letter that Healthcare Policy and Financing in conjunction with the new Cabinet of Saving People Money on Healthcare wrote to the Colorado Hospital Association, the first item says, can we free up $12 million to help our rural hospitals, because they don't have all the assets and resources that when we change the payment methodologies, as we're talking about potentially going forward, they don't have all the assets, resources, expertise, models to be able to model out what does that do to their revenue flow. So something like a reinsurance bill or an alternate payment methodology or a change in, because they handle so many things in the rural community, it's really hard for them. So one, the overall change in EAPG to help you where we might have hit you with unintended consequences. And the second, through the Hospital Transformation Program, to try to push about $12 million to open up to some of the resources that you need, actuaries, modeling systems, consulting, strategists, to help and to give you enough time in advance to make sure that there aren't the unintended consequences and to keep this dialogue. And I want to thank you for being here today.
Wouldn't miss it.
Yep, so
Real quick, the only thing I would add on to that is that I think that goes back to Steve's point earlier too, right? And our response to Steve, that we're going to commit to getting out from just the Denver area to have those discussions and make sure we're thinking through those things and hearing those voices. And to Kim's point, I mean, there's a reason why Washington has a 2-year runway for their plan, right? It's so exactly, so whatever we do, we're giving enough time to actually make sure that we're dealing with giving carriers, providers, everyone, consumers, the ability to react and be prepared for it.
yeah, so we want to make sure we hear from critical access hospitals, you know, as we develop this in the public option and what that looks like. Other sort of thoughts about sort of who would be helpful to hear from as this public option is being developed. All right, yes, sir.
I'm Andy Rose, and I educate interns and therapists in Boulder County. We've been a Medicaid resource in Boulder County for about a year and a half. We went through the last July reorganization where the behavioral health contractors had to recontract 7 RAEs. I'm curious about the answer to your question, the knowledge base of the regional accountability entities might be really useful, given the time pressure here. You know, having a bunch of new clients show up in my office with life estate option plan might look like the easy road. And I'm curious about the attachment to the RAE system. And yeah, just that. Like, you could build this right on top of the RAEs. I'm wondering if you're going to do that. And, you know, from a behavioral health point of view, we're a stepchild to, not as a term here, to the medical providers, in that we have to contract separately with all the RAEs, where the medical providers just have to go to one. So just curious about the habit that Colorado has of managing this kind of health delivery through these regional accountability entities, if we're going to keep on doing that.
So may I ask, maybe we're not going to, if I could ask, maybe not that we're going to respond to the question, but that is something that we'll figure out, sort of raise, or if there's something quick you want to say, just because we got to get through meeting frequency and needed work groups in the next 15 minutes. So
sure. So the question is, how are we going to maximize the existence of regional accountable entities? And I would just say there's always an intention to maximize the gifts. And that is a gift that we have these regional accountable entities with tremendous insights into the local needs of each market, both the unfulfilled needs, everything from homeless shelters to food banks, so social determinants of health, plus the largely insights into the population that we're talking about trying to solve for. So I think there's an intention to maximize the gifts, but I don't think we should set our sights that, oh, we're going to use this existing model and that is the gift all be all. There are a lot of things we're trying to change in that area to raise the bar, and we would need to raise the bar tremendously to have that be the infrastructure, and that's, you know, the one that's in contract with those folks, and we're working on raising the bar, but I don't want to limit where we're going.
Very quick, I promise.
Okay.
The only other thing that you got to think about it, I mean, as you're having that conversation, it goes exactly back to the risk component that I was talking about earlier, right? So if we're building this on top of the raise, to use the phrase that you had, we're talking about some significant risk that we need to be cognizant of, and for the state that we need to be cognizant of and thinking about as we do that.
And so I hear some of this is how do we look at existing infrastructure and what can be built off or what couldn't be, and then also sort of this mental health component along with this rural component. How do we think about what that role it plays in the public option? Other, yes, sir.
Hi, my name is Gary Matchell. I'm a broker.
I forgot to answer
Look
that.
at my talk straight here. I heard from, there's multiple groups in here. One of the groups that has not been mentioned is the broker community. I'm not talking compensation. However, we talk to clients every day. We advocate for our clients. We're the first person they come to when they have a problem. We're a group, I think, that you really need to engage, not only as a distribution channel, but as someone who has a lot of thoughtful thought and ideas and problems from our clients that we work through every single day. We hear the problems from the exchange. We hear the problems from TikTok. We hear problems all over the place, and we have to navigate them all. I think we need to have a seat at the table to help you figure out what you need to make it better.
Sure, Gary, thanks for being here, and I was glad that Jackie was here from Cashew too, but I'm fully at least expecting you all to be at the table and be a part of these conversations. So please come, give us your thoughts. You're absolutely correct that you all have insights into things that are going to help us figure all of this out. So please don't be shy, absolutely. Did you get the impression that you all weren't a part of the conversation? And the point was, for the folks on the phone, just that we need to make sure that we're keeping the brokers in the conversation as part of the conversation.
I will tell you that a large portion of the broker community, and I meet with 15, 20 on a regular basis, we don't feel like we're a stakeholder in any of the processes. Not in any processes that are going on. We don't feel like we've been included. And I would say, to your point, we introduced everyone, we get omitted. When anything goes out from C4 anywhere, brokers are mentioned very last. So we're feeling very devalued in the marketplace. And that also gets compounded by we earn a living. We're constantly getting hammered on our compensation. And that's why you have a lot of brokers leaving the market.
So this is Kim. So Gary, first I made those opening comments, and I apologize for neglecting to mention brokers. We do look at the brokers as one of the strengths in the marketplace. You have tremendous insights. You bring tremendous value. You have analytics. You have information. You represent. You're the eyes and ears of the market. So I apologize for not representing. If you haven't felt included, I apologize for that. We try to include everybody, and it's the intention to value and include and to maximize the insights of the broker community.
And what I'll add is this is the table. So for sure here, and again, when I go back to one of the, I won't go back to the slide, but one of the big important roles that you all play is being that conduit to the community and either bringing other people here or for sure bringing their voice or trying to figure out how we engage. And so welcome, we can have a conversation afterward if there's a better way to engage some other folks to make sure they feel included in a part of it.
I always have lots of ideas.
Okay, great. So we will jump on that. I'm going to take one last comment on sort of who do we need to hear from or what models we want to look at, and then I want to move into meeting frequency. Yes?
I think my question will go to that.
Perfect.
Edward Dower, I represent One Consumer. Somebody mentioned social determinants of health, and that triggered a thought in my mind. Aggregate costs in healthcare are partly a function of aggregate demand, which is in turn driven by health. To what extent will connections with initiatives in social determinants of health part of this conversation? I don't know to what extent they have been with respect to Medicaid so far, but it seems to me that at least creating connections that we're not trying to get our arms around it, that seems to be a useful sort of thing we might engage in.
So I think it's a great point, but I also want us to make sure that we're at least realizing that what we're tasked with in the legislation specifically, and the time period that we have to accomplish the goals that the legislation has set forth. So the legislation really is, from my viewpoint, and I think this will be part of the conversation as we go, but the legislation is really directed at trying to find a path forward on affordability for the first step, because affordability gets back to the uninsured rate. Now, after we get through that first step in that 4 months, assuming that we can come up with a product that really does accomplish that, I think you're absolutely correct that part of the conversation as it evolves will capture those types of things, the social determinants of health being at the very top of that list. But I also think that there's a component of the social determinants of health that it really is going to take us to a focus on something bigger than just the individual market. We're going to have to look at the small group market and in particular the large group market if that's where we want to go. The large group market, remember, a big number of the players in the large group, quote unquote, large group market are our counties and our school districts. Right, so if we free up resources from our counties and our school districts, those resources have to go someplace. And that's where the conversation, in my mind, really gets interesting on social determinants of health and other things. But if we're just focused on the individual market, where we're freeing up resources for the individuals in the individual market, it gets difficult to find more money on top of that to get to capturing problems like the social, or dealing with issues like the social determinants of health and those conversations. But if we make this a broader conversation, maybe there's something that we can do on that point.
This is Kim. I'll just add that there are a couple of work streams ongoing that social determinants of health are more primary. The one is 1320, which was transparency into the hospital's contributions to community health needs assessments, and transparency around that gets at social determinants of health, and that was put forward by our advocates. And so that's been time well spent, that bill that passed in the last few weeks of the session. The hospital transparency also starts to relate to some of that. The affordability roadmap rolls out community by community, and in looking at costs, we look at social determinants because you're trying to meet the needs of the community, get people covered universal health care, and control the cost. So those work streams are more primary than this one would, and Medicaid spends a lot of time on social determinants of health. So I think there'll be a secondary in this, but always a consciousness that we have to have.
All right, so our next meeting is June 13th. And so we won't have a meeting probably before June 13th, but just regular in terms of frequency, what are you all thinking about would be good for folks to be able to get sort of participation, engage, and get to a product by middle of October? What would be the frequency of meetings that you all would enjoy?
Every other day.
Besides every other day. I mean, does monthly feel more than monthly?
Do it in months. You only got 4 months.
So potentially bi-weekly, or every 2 weeks. Every 2 to 3 weeks, we can maybe say, I think we'll also try to ensure that there's meaningful work that can be put on the agenda. So we won't have a meeting if there isn't really a reason to have a meeting. But I am hearing there is a sense of urgency from both sides of this table. So we will figure that out. Are there thoughts about sort of potentially needed work groups that you think should maybe do even work in between, because that might be a way to do that? And that could also potentially be some homework for the next meeting. Maybe think about what kind of work groups would be helpful to have. I know we had another comment on the phone, just remembering that the Western Health Alliance and maybe all the health alliances could be good resources to engage as we do this work. Yes.
How do you want us to give you input? Maybe I missed that.
How would we like them to give us input?
So we will shoot out an email blast with exactly how to do that.
Yep. So we'll share an email. So please, again, make sure you signed up on that sign-up sheet so that we will email you. And then, many of you.
Where is the sign-up sheet?
Does anybody see the sign-up sheet?
On a clipboard.
It's on a clipboard. It was circulating around.
Or the right
Back in the back of the room.
RSVP. Does the RSVP list have email addresses?
Not all, no, so that was one of the key things that we, yeah, some, but not all.
So that clipboard is going to be in the back of the room. If you have not signed it, make sure you sign it before you leave. And so we will give you sort of contact information. Some of you know me. Feel free to just email me, and I can make sure I can get comments and thoughts back that way as well. So if you don't sign up, just email me. We'll take care of it. Any other sort of last thoughts? We know at the next meeting we're going to talk about what we're actually doing sort of towards that process. That was definitely one of the requests I heard. Other things you want to make sure that we discuss in the next meeting. All right. I thank you all for being here, being at this table, being a participant. It's going to be what makes this really work. So you guys are great. Thank you, thank you, thank you.
Hold on, is it coming through there?
Yeah. Okay. So for folks on the phone, we're going to hang up right now.